Alrighty, so I think now is a good time to get started. Welcome back, everyone, after the Thanksgiving break. I hope you all had a lovely, restful weekend. We are very excited this week to return to the DBMI weekly seminar. This is actually one of our special seminar series in diversity, towards diversity, equity, and inclusion. And this week we are incredibly excited and honored and thrilled to have Dr. Ziad Obermeyer, Associate Professor at UC Berkeley. So Ziad trained as an emergency doctor, and he still gets away as often as he can to a hospital in rural Arizona to work in the ER. But these days he spends most of his time on research and teaching at Berkeley. Inspired by his clinical practice, he builds machine learning algorithms that help doctors make better decisions. He also studies where algorithms can go wrong and how to fix them. His work on algorithmic bias has been highly influential both in public debate about algorithms and in regulatory oversight and civil investigations. He is a Chan Zuckerberg Biohub Investigator, a faculty research fellow at the National Bureau of Economic Research, and has been named an emerging leader by the National Academy of Medicine. His work has won numerous awards and appeared in a wide range of journals, including Science, Nature Medicine, the New England Journal of Medicine, and leading computer science conferences. He is a co-founder of Nightingale Open Science, a nonprofit that makes massive new medical imaging datasets available for research, and Dandelion, a platform for AI innovation in health. Before coming to Berkeley, he was an assistant professor at Harvard Medical School and a consultant at McKinsey Co. So without further ado, because I'm sure there is much for us to learn, please everyone give a warm welcome to Dr. Ziad Obermeyer.
Thanks so much, Courtney, and it's really a pleasure to be here. I actually am always particularly happy to be presenting to groups like this one, the sort of the DBMI type groups, because I think, there's a certain community of people that I think can speak both the language of computer science and, statistics, but also of health. And I think both of those languages are really sorely needed to do good work in this field. So anyway, wonderful to be here. I'm going to try to come in at around 45, 50 minutes. So that we can have time to chat afterwards. I'll just assume that things are going well unless I hear otherwise. Okay, so I think because I've worked a lot on algorithmic bias, I sometimes feel like I need to start off by clarifying that I actually think there are a lot of really great things that we can do with AI and health. A lot of what we do in clinical medicine, but also in population health or health policy, is about risk prediction, which is, forecasting what's going to happen based on things we see today. Diagnosis, which is predicting the likelihood that someone has a particular disease or a vector of diseases based on the things we observe about that patient today. So all of this stuff is great. I am super optimistic about this, broadly speaking, as a force for good in medicine. But of course, along the way, there are lots of ways for algorithms to go wrong. And in particular, I'm going to talk to you about ways in which they can reproduce or even scale up racial bias. And so I'm going to go through two case studies that I've worked on. One is the kind of evil twin, an algorithm that scales up racial bias in a population health management software package that is used and sadly is still being used to make medical decisions for millions of people. And then the good twin next, which is an algorithm that fights against racial bias that's built into medical knowledge and has been for the past several decades. And along the way, I want to focus on some common themes. One is making sure that algorithms are aimed at the right target variable. And the second is some applied work that I'm doing to basically try to take this research and some of the important things about the research out of the proverbial lab and into the world. And one of those things is that I've come to realize there's a need for data platforms where people like you and people like me can actually do this work and can touch data and make progress on a lot of important things in medicine related to algorithmic bias and otherwise. Okay, but first, the evil twin. So the setting that we were working in, this is project that started several years ago, published a couple of years ago, is in population health management. So a lot of health systems basically realize that there's the small fraction of patients that they take care of that have very high costs, but are also getting poor, fragmented, low quality care. And so what every health system in the world, as I'm sure you know, has been investing in is some variant of what's called high-risk care management, which is you're responsible for a big group of people. Some of those people are going to get sick, and you'd like to know which ones are going to get sick today so that you can help them. And the particular package of help that we're talking about is essentially attention from a human. In this case, a trained nurse practitioner, most commonly, who's basically on call for you as a patient. So if you need a prescription refilled, if you need someone to come to your house and look at your foot, if you need an appointment with your primary care doctor, these people can make it happen. So it's just a very high touch thing. Because it's so high touch, it's expensive. So you can't do it for everyone in your population because it just takes a lot of resources to do this well. And so you need to target that program to the people who are going to benefit from it the most, which makes sense. And that's why algorithms are so commonly used for this thing, because you've got a huge population of patients, you need to triage them, you need to get the right ones into care. So I'm going to talk about a particular piece of software that is used to screen about 70 million patients per year in the US. There are a family of algorithms that work just like this one that are effectively used for the majority of the US population every year. So the scale of these algorithms is one thing that I learned from this work. The scale on which algorithms are already deployed in the healthcare system, not really in the clinic, but on this administrative population health backend of medicine is just enormous. What all these algorithms are trying to do is find patients who are going to get sick. So what they do is they say, okay, I'm going to make a prediction today. I'm going to look at every piece of data that I see about this patient over the past year. I'm going to make a prediction about who's going to get sick. And I'm going to measure that by just totaling up all of the healthcare that that person uses over the next year as my measure of sickness. And adding up all of the healthcare costs that come from that utilization and predicting that number. So I'm going to just make that prediction. I'm going to use that prediction to triage who gets access to health, to help with their chronic conditions and who doesn't. Okay, we were working with one healthcare system that used the algorithm in a specific way that looks a lot like, as we've learned, many other healthcare systems use it. So the algorithm is outputting some distribution of risk scores. And the health system picks the top 2% of those people and it fast tracks them into this high-risk care management program. So those people, unless there's some administrative reason not to, they get enrolled in this extra help program, like the VIP program for you as a chronically ill person who needs help. You get automatically enrolled if you're in the top 2%. The next half down, approximately, there's like a human in the loop step. So the algorithm generates a list, and that list gets shown to the primary care doctors 3 times a year. And those doctors are asked, well, check off here are the ones that the algorithm thinks in your patient panel would benefit. Check off the ones that you think you'd want to be enrolled. So you get enrolled if the human says enroll you, and everyone else is just screened out. So basically, the algorithm score is the policy. The algorithm score is dictating who gets screened out, who gets shown as a candidate to the doctor, and who gets screened in. So that is the policy. It is a direct function of the algorithm score. We were interested in studying, because of the way the algorithm was constructed, as I already mentioned, we were suspicious that this algorithm was not working the way it should. And we were interested in particular in studying racial bias. But to study racial bias, you first need to define racial bias. And I think this is a recurring theme of some of the work that I've done, and it's quite hard. And so the way we defined it in this particular case was to try to get to a very crisp definition. And so here's my definition of bias in this case. People with the same score get treated the same way. They're getting the same access to this helpful program that's going to help them manage their chronic conditions. So given that, 2 people with the same score should have the same need for that program. They should have the same health needs. And in particular, the color of their skin shouldn't matter. But that's not what we found. And the whole paper can basically be summarized by this graph. So I'm just going to walk through it for a moment. So on the x-axis, we have the algorithm risk score. So we binned people into percentile bins from lowest risk on the left to highest risk on the right. On the y-axis, we're tracking from the moment that algorithm outputs a score, we're going to look at their health needs over the next year. So we're going to look at how many chronic conditions flared up. So if you went to the ER for emphysema, that's +1 on the scale. If you needed to see your doctor for optimization of your congestive heart failure medications, that's +1. So we just add up all of those encounters and visits for chronic conditions over the next year. And we do it for Black patients in the purple line and white patients in the gold line. And what you can see is that the purple line is consistently above the yellow line. So no matter where you draw the line, like a vertical line, people with the same score, Black patients go on to have more encounters for these chronic conditions than white patients, no matter where you are in the risk score distribution. So one thing that's not obvious from this graph is like, well, how much bias is this? And what I can tell you today is that if we just look at the fast track, these are the people who get screened into the program. The fast track as recommended by the algorithm is 18% Black. Now, you might look at that and say, well, what's the base rate of Black patients in this population? That's only 12%. So first impression is like, oh, this algorithm is overrepresenting Black patients in the high priority group. So this doesn't look like a biased algorithm at all. The problem is that that doesn't take into account the fact that Black patients need help a lot more than white patients based purely on their health needs. So if you just measure these chronic conditions and said, well, I want to just put people in the program based on their chronic condition burden, you'd actually get a fast track that's far more Black than the algorithm recommends. And so there's a lot of bias encoded in this algorithm. A really important question is, where does this bias come from? And to answer that question about where the algorithm is going wrong, an important first step is where the algorithm is going right. And so on this graph, what I'm showing you is same x-axis. So this is the algorithm score on the from low to high. On the x-axis, Black and white patients on those two lines. But now on the y-axis, I'm showing you not how the patient's health did over the next year. I'm showing you healthcare costs. And what you can see is that these lines are very closely overlaid. So the algorithm is predicting healthcare costs extremely well, and it's doing so for both Black and white patients. So the algorithm is doing a great job doing the thing that we told it to do, which is predicting healthcare costs, and it's doing that job very well for both Black and white patients. So putting this together, the algorithm is biased for predicting health and unbiased for predicting cost. And that is because Black and white patients don't have the same correlation between their health and their costs. White patients have better access to healthcare for a variety of reasons related to socioeconomics. This is a fully insured patient population. So this isn't insurance, but even when you're insured, there are lots of frictions that prevent you from accessing healthcare on a day-to-day basis. If you're socioeconomically disadvantaged, and on average, Black patients are more so. There's another channel, though, which is that the health system just treats Black patients differently. And that's been established over years and years of research and very elegant experiments, both in hospital settings with real data and in experimental settings in the psychology lab. And as a result, conditional on health, if you take two patients with the same health, measure it however you want to measure it, Black patients cost less. In our sample, is about $1,000 less per year, holding constant the basket of health conditions that Black and white patients have. Black patients cost $1,000 less per year. It's a big difference. So when you tell the algorithm to predict cost, and it does so accurately, you are in the same breath telling the algorithm to be biased when it's predicting health. So what this suggested to us was that there's a huge benefit to finding better targets for prediction. I think, one reason that when people, I think, first saw the results of the study, I think one very understandable reaction, which I had too, is like, well, insurers and population health management people actually care about costs. So of course they're predicting costs. That's what they care about. But actually, cost is not necessarily the thing that you'd want to predict, even if you just cared about reducing costs. The program, these high-risk care management programs, they don't reduce reimbursement. They don't turn down the cost knob. They help people manage their chronic conditions so that they stay out of the emergency room. They have fewer doctor visits. They have fewer flare-ups of these conditions. So it's not at all clear that even if you were purely interested in cost minimization, that the right thing to do is to predict cost, because a lot of costs are predictable but not avoidable. And so you might actually care a lot about predicting someone's health status. So we developed a number of other proxies. So cost is one proxy for health, but so are the number of chronic conditions. So is your blood pressure. So is the laboratory measurements that we do on you when you come in for an annual visit with primary care. And so we worked with the original company and the team that developed this algorithm to retrain the algorithm on a basket of conditions that was much more closely tied to health than it was to cost. And on one measure of bias that we developed together, this retraining process in the same data using the same ML pipeline that they already had huge benefits for bias. So it reduced the amount of bias in that algorithm by 84%. And I'd also say that that new algorithm was a much better fit with the business purpose, which is finding people whose health is going to worsen and helping them before their health worsens. So I think that finding those better labels, those better proxies to train algorithms on is a very, very high value activity that can be done without collecting new data. It can be done in the same data set with the same pipeline, just rethinking exactly what the algorithm should be doing. Okay, so let me distill this into lessons for what I've learned studying algorithmic bias, not just in this example, but in a number of applied work that I've done since then. So there are basically 3 ingredients to every single piece of work that I've ever done on algorithmic bias. And I'm just going to give you the cookbook, the recipe for these studies, because I think it's a very useful one, and it's a very simple one. The first thing that you need, obviously, is the algorithm score. And the algorithm score often implies a policy. So in our case, it was who gets access to this high-risk care management program. So the algorithm score is being used to do something in the world. It's being used to make a decision. It's being used to screen people, triage people. And you need to figure out what that is to understand what the algorithm score is and what it's doing. And in particular, you can't take that score at face value. You can't just say, well, they decided to predict healthcare costs, so I'm just going to assess it on how this algorithm is predicting healthcare cost. You actually need to figure out, forget what the algorithm is predicting, like what label it was trained on. I don't care about what label it was trained on. I care about what label it should be trained on. What is the actual information that in an ideal world, you as a policymaker would want to guide your policy? What's the information that's missing from the thing that you have available to you today that would improve the quality of your decision makings? And I think the problem with bad algorithms is that they distort those decisions. They distort the policies that result from the algorithms in ways that actually cause harm. And a really important point is that these things cause harm for everyone. So there are huge racial disparities in who gets harmed more. But I think a really important thing to keep in mind is that these things are bad for everyone. They distort policy away from the optimal policy. And as a result, there's a big constituency of people that will support redoing these algorithms and making them better, not just because doing the right thing reduces racial bias, but because doing the right thing actually makes these algorithms work better for everybody. But figuring that out actually requires a ton of careful work and domain knowledge to figure out, well, what should the algorithm be doing? You can't answer that question in a purely data-driven way. You need to figure out, well, what's the goal of the algorithm? How's it being used? What would be the thing that the algorithm should be informing the decision maker of to improve the quality of her decisions? And the last thing is the definition of algorithmic bias. I think the way we've defined it in all of the work we've done is to say, well, I'm going to look at this ideal target. So in this case that I just talked about, it's someone's health, measure it in a variety of different ways because health is a complex and multidimensional concept that requires a similar measurement strategy. But however you measure it, you look at health conditional on the algorithm score, and you compare health between Black and white patients, between male and female patients, between urban and rural patients, whatever your groups of interest are. And that's our definition of algorithmic bias. It's differences in what the algorithm should be predicting in the ideal target of the algorithm by group, conditional on the algorithm score. And I think that definition, even though it is difficult to articulate and to measure and very painstaking and very intensive of domain knowledge, it is a much better definition than simple heuristics about, does this algorithm use a race correction? Does the algorithm over or underrepresent people relative to the population base rate? All those things are important to pay attention to in some settings, but really miss the point in terms of quantifying algorithmic bias. Algorithmic bias is the harm that's induced by the algorithm in decisions as a result of these distortions in what the algorithm is doing relative to what it should be doing. And that's how I would think about bias in a lot of different settings, both in health and in other sectors that I've worked in. So I wanted to mention that we've done a lot of applied work on these topics that started because we got a lot of media attention from this initial work. And so a lot of people came to us with algorithms that they were worried about being biased. And the glass half empty, unfortunately, is that we did find bias almost everywhere that we looked. And that's in parts of the health system as diverse as population health management, prediction of who was going to get individual diseases or not, often because people were predicting billing codes rather than actual diseases. And those two things, as we've learned through doing our work, are quite different. A billing code for depression is very, very different from actual depression in a population. There's also a number of operational algorithms that are used to optimize clinic schedules or do other things on the back end of the health system that turn out to bake in a lot of inequalities in access to care. So all those things were bad. But the good news is that in thinking carefully about, well, what are these algorithms doing today, but what should they be doing tomorrow, we were able to come up with a plan for retraining almost every single one of those algorithms in the same data set on a less biased label by thinking carefully about what that algorithm should be doing. And a lot of that work is described in this document, the Algorithmic Bias Playbook, that you can download and read about at your leisure. Okay, so let me actually pause there for a moment and just see if there are any comments or questions on that first case study before I move on to the next one. You're all very polite. I should note that I'm used to, my usual my modal presentation is to economists who have no hesitation and jumping in and interrupting whenever they have a question. And I actually kind of like that, and think you all should do the same. So please interrupt me. I'll keep going, but definitely don't hesitate to jump in. Okay, so here's the more optimistic part of the talk. And I want to switch gears completely away from population health management and talk about pain. So pain is very common, as unfortunately the opiate story has shown, but pain is also very unequally distributed in society. And so when you look at these large studies of who has severe pain over the past couple of days, it's really striking. It's one of the most striking disparities in medicine. If you think about the experience of being in severe pain, that experience is twice as common in Black and other non-white populations relative to white populations. There are similar gradients by income and education. And so, I think there's a standard story for this, which is like, well, yeah, everything is worse in some populations. And so you could imagine the distribution of conditions that cause pain is worse in Black populations than in white populations. And that's true to some extent, but actually the story is not that simple. It's not just that. So we're going to be talking about knee pain. So a very common cause of knee pain is osteoarthritis of the knee. And it's not the case. So it is the case that Black patients have a higher rate of osteoarthritis than white patients. But that's not the whole story, because we can actually adjust for that in studies. So we can say, okay, we're going to condition on the degree of osteoarthritis in the knee. And so now we've zeroed out the differences in population prevalence. And then we're going to ask patients about pain, conditional on osteoarthritis. So concretely, we're going to take two patients who have the same degree of osteoarthritis on their X-ray, and then we're going to ask them, how much pain are you experiencing from this knee? And what those studies find is that Black patients, poorer patients, patients with lower educational attainment still report far more pain, even when we condition on the X-ray, on the severity of arthritis in the X-ray. So I think that's a very striking finding, and it's a bit of a mystery, but it's a mystery that a lot of people have tried to solve. And I'll just tell you a couple of explanations for that from the literature. And I think the explanations largely follow the logic of, well, we've zeroed out the contribution of the knee. And so if the source of pain, the source of this pain gap between Black and white patients, if it's not coming from the knee, well, maybe it's coming from somewhere else, and maybe it's coming from psychology. And this literature is actually a very good literature. It's not a pejorative literature at all, because I think there's a lot of work that shows that stress can make similar stimuli more painful, and rates of stress and anxiety are certainly higher in disadvantaged populations. There's also a literature that looks at how anxiety and depression are expressed in different linguistic and cultural groups, and those can be expressed as pain in different groups. There's also just a bandwidth story where patients who have more socioeconomic or other problems actually just have less mental bandwidth to cope with pain, and so that can result in higher pain scores. So all these mechanisms, I think, are real. The other set of mechanisms that is often cited is that people have less access to things that help manage pain. So maybe the medical system is treating Black patients differently and giving them less access to medication, physical therapy, et cetera. So all these things could produce differences in pain conditional on the degree of osteoarthritis. And so I just want to walk through a very concrete scenario where a patient walks into your office. So you're a primary care doctor, a patient comes in with knee pain. You send that patient for an X-ray. And if a lot of this literature is right, then that literature, if that patient is Black, is going to come back, that the X-ray interpretation is more likely to say, well, this patient's knee looks fine. I can't see any arthritis or very mild arthritis relative to the pain that you say she's reporting. So you're going to look somewhere else. So you might, instead of sending that patient to an orthopedic surgeon, you might send them, to some other provider, a therapist, or just somewhere else in the health system, or more likely, based on my own experience working in the medical system, you might just say, well, there's nothing I can do. Good luck, and you can go home now. So, so I think that's the current situation. A lot of what I've said depends a lot on conditioning. So conditioning on the severity of disease in the knee. And so when we say that, and when these studies do that, well, what do they do? How do they actually measure that? Well, let me show you the current state of the art. It's a person looking at an X-ray and looking at very specific parts of that X-ray at different compartments of the knee and grading the knee on very specific criteria that were developed to measure arthritis based on the X-ray appearance in the 1940s and 50s by these two gentlemen, Drs. Kellgren and Lawrence. And Drs. Kellgren and Lawrence did their initial work studying coal miners in England in the 1940s and comparing those coal miners to office workers in England at the same period. And when you go back to those original studies, there is no mention of the race or the sex of those patients because they were all the same. And so that's where our definition of osteoarthritis comes from. And so you might think that this could also be a problem. In addition to all of the psychological mechanisms that we talked about, the fact that our very definition of arthritis was set in a very specific time and place and in a very specific population that does not reflect the patients that doctors see in the office today. Maybe that has something to do with the pain gap as well. So the specific hypothesis here is that human radiologists are looking for a set of things that were defined in white male populations 60 or 70 years ago. And as a result of that overfit to a particular population, they are overlooking causes of pain in the knee that affect other groups. And so you might think, well, this could be a great job for an algorithm. Algorithms are, as I said, they're going to have all these great effects on the medical system. They're going to do all these great things for us. The problem is that if you just literally take the usual playbook of algorithms in healthcare, what do those algorithms do? Well, they get a bunch of X-rays, knee X-rays in this case, and then they train an algorithm to read in those X-rays and output what a human would have said about those X-rays. And this is a playbook that starts with ImageNet and goes all the way through most of machine learning in medicine. We're predicting human labels and trying to match human performance or occasionally exceed the performance of individual humans. And if you think that the humans are biased, notice that this would be exactly the wrong strategy. This is not at all what we want to do. We're going to get an algorithm that exactly mirrors all of the potential biases that humans have in their interpretation of the X-ray. Okay, so once again, we're going to try to find a better target to anchor this prediction on. And so if the current state of play is to say, okay, well, I'm going to learn from the radiologist. I'm going to input the X-ray. I'm going to output the Kellgren-Lawrence grade on a scale of 0 to 4 from that X-ray. There's another way that you could do it. And in fact, there's another human that you could ask about the knee, who is not the radiologist, but whose opinion about the knee is at least as important as the radiologist, and that's the patient. So what we did in this paper, and this was led by Emma Pearson, who is now your next door neighbor at Cornell Tech. She's fantastic and has a bunch of really, really interesting papers on health in general, but on algorithmic bias in health and elsewhere in particular. So we set about training an algorithm that actually predicts a patient's pain score from the X-ray as an alternative measure of disease severity in the knee. So finding the data, and this is the theme I'll come back to a little bit after I finish going through this story. Finding this data is not easy. So it's very easy to find data that link the X-ray to what the human said about the X-ray. That data is sitting in one place in every health system. It's called the PACS system. It's the system that radiologists use. And so it is super convenient, just like it was convenient to predict cost as a measure of healthcare needs, because it's one number. If it's missing, it's 0. There's no data cleaning or whatever you need to do. This is also very easy. So why does everybody predict what the radiologist said? Well, because it's easy, because you can get a data set of the X-ray and what the radiologist said. And then you don't have to link it to any other data sets. You don't have to, there's a ton of, your life is just much better if you just do this thing. It's a lot harder to find data that link an X-ray to what the patient said about the knee. And I think that's it's a good encapsulation of the fact that the medical system cares a lot more about what doctors say about their bodies than what patients say about their bodies. But that's the way things are. We were lucky enough to have access to an NIH-funded study that made its data public. And so I'll come back to that in a second. But once you have those data, then it's an equally easy problem, because you just get all the X-rays, train a network to predict the pain score. And there's a very nice feature of predicting pain, which is that if it's predictable, it's not noise. So I think a lot of people have very reasonable suspicions about pain score, because especially doctors think, well, we're asking people about pain, but like people's mood can affect pain, like what they had for breakfast can affect that. There's lots. So it's not that people think this is like exactly a random number generator. They just think there's a lot of things that that go into that reported pain number that has nothing to do with the knee. That has everything to do with like, the context, or like, whether people are looking for Percocet, or so there's a lot of suspicion of this pain score. But if we can predict that pain score from the X-ray, there's something in that X-ray that's letting us predict the pain score. And it's not in the head or coping or in society, it's in the knee, with some caveats that I'll come back to in a second. But that's the basic principle of this analysis, is that we're only feeding the algorithm the pixels of the knee, and it's doing a pretty good job of predicting pain from those pixels. So there is some signal for that pain in the knee. Okay, so here's the key fact from the study, is that in this population, so this is a NIH cohort study, I think it's about 30 or 40% Black. So they had, there was a lot of effort put into getting a broad and representative sample of the population. And if you just compare Black and white patients, their average pain score, not taking anything into account, this is just the average difference, it's enormous. So this is a fairly counterintuitive scale where no pain is at 100 and severe pain is less than or equal to 86. I don't know how they made the scale. It doesn't make any sense to me, but that's the scale. And on that scale, the difference between black and white patients, unconditional, is about 11 points, which is more than halfway between no pain and severe pain. That's just the average difference. So crazy difference. And once again, reminds us of these huge disparities in pain in society. So we have the Kellgren-Lawrence grade, the degree of osteoarthritis in that study. And so we can adjust for that. So basically we run a regression of pain on black, white, controlling for also Kellgren-Lawrence grade. And that reduces the black-white difference, this pain gap, the extra pain that black patients have relative to white patients, by about 9%. If instead we control for the algorithm score, our measure of disease severity, which is the predicted pain from the X-ray, we get 5 times more of a reduction in that pain gap between black and white patients. So the algorithm is explaining a huge fraction of this pain gap, not because it was trained on, the pain gap. It was just trained on pain, but the algorithm is finding signal for pain that is not being captured by the Kellgren-Lawrence grade. And that seems to be disproportionately affecting black patients because it is making a huge contribution to reducing this gap, the unexplained gap in pain between black and white patients. Now, we get similar, although less pronounced results for income disparities and educational disparities, but the headline here is really the black-white disparities that are enormous. So there are a lot of things this could be, and if you have patience or if you need bedtime reading, you can look through the paper where we go through a lot of other things. So could this just be reconstructing race or body mass index or any other things that correlate with pain? No. In fact, in that regression, we can control for those variables directly, and those variables do not change the algorithm's explanatory power for pain. So if the algorithm is reconstructing some noisy version of race, if we controlled for race, that would take away the algorithm's explanatory power, and that's not happening. We cross-validate across study sites, so it's not that. It's not even the algorithm doing better weighting of known features that the radiologists are already capturing. The radiologist features don't explain all of the prediction. In fact, they only explain about 2/3 of the prediction. So the algorithm is finding a bunch of stuff, even in this relatively small sample on which it was trained, that is new to radiologists and not currently incorporated into what radiologists are grading. To go back to one of the themes that we talked about earlier about harm, well, what's the harm in this decision? So to go back to our 3 ingredients, we have, in this case, the algorithm score. I'm going to say the algorithm score is basically the osteoarthritis score. That's our medical algorithm that we had been using. But that's not the true thing that the algorithm should be. The true quantity that the algorithm should be producing is some measure of severity of pain in the knee. And so what we actually want to do is to see, well, how is this difference between disease severity and osteoarthritis grade distorting important decisions? And so here's one important decision is who gets a new knee? So to get a new knee, the medical guidelines and perhaps more importantly, the insurance guidelines say you need to have severe pain, but you also need to have severe arthritis. So who is that going to disadvantage? People who have severe pain, but not severe arthritis, even though they have an organic problem in their knee that might respond well to this treatment. And so what we do is we take patients with severe pain in our sample, and then we say, okay, how many of those patients would meet the osteoarthritis criterion? Who would be above the cutoff for severe pain and severe osteoarthritis that would get you a new knee? So that's according to the radiologist. But now we're going to swap in the algorithm's severity score instead of the osteoarthritis score. And then we're going to take the same number of patients and ask, okay, how does that change the composition of that patient pool? It would actually double the fraction of Black patients who are eligible under the guidelines and under insurance rules for a knee replacement surgery. Ahmed, you have a question. Sorry, I just saw your hand.
Yeah, I do. It's related actually to the previous slides that you showed.
Yeah.
And then can we go back to that quickly?
This one?
Well, the one with the graphs. So I had the first question then is, I think you mentioned a couple of reasons of what the algorithm was not doing, i.e. it was not just, differentiating by race or whatever. Do you have an idea actually then what was it picking up? What were the new signals that it was finding? And then secondly, there still seems to be pretty large gap. Do you have an explanation for what that gap may be driven by?
Yeah, so I think so what is the algorithm, seeing? I think is just a really, really important and interesting question, and that we don't have an answer to. So the thing we did is the standard thing that people do in this situation, which is to, put up the saliency mapping and figure out, okay, like in an image, if you perturb some parts of the image, how does it affect the score? So what we found is that the algorithm is looking at the joint, the knee joint. So that's good. It's not looking at other parts of the image, but I think it really highlights a deficiency of this interpretability playbook as it currently stands, because what that can tell us is like where, but not what. And I think that's something I'm super interested in working on in other settings, but I don't have a great answer for what it's looking at. As far as why it's not doing more, I think that this algorithm is trained on a very small sample, like it really marginal for what you can do in deep learning. I think it was around like 4,000 or 5,000 images. And so I actually am pretty sure that if we had, reasonable sample sizes of X-rays linked to pain, which is something that I'll come back to in a second, we could do a lot better in this same exercise.
Thank you.
Okay, so let me to talk about the applied work that came out of this project. Let me observe that pain, I find pain super interesting. I think it's a great, like deep learning problem because it's a huge mystery. It's like a medical mystery where pain comes from. When I work in the ER, people, like the most common thing people come in with as a symptom is pain. And I'd say that I get to the bottom of what's causing the pain in about like 10 to 20% of patients. And that might be because I'm not very good, but I'd say even my colleagues who are very good are 20 to 30%, maybe. So, and pain is just one of the deep mysteries in medicine that are also great machine learning problems. So sudden cardiac death, which cancers metastasize and which ones don't? COVID, who's going to get bad COVID? Who's going to have a runny nose? These are all problems where machine learning has something to say, where applying ML to images, EHR data, et cetera, could yield huge insights for medicine. And I think those tasks should attract more interest than they have, because there are a lot of researchers, there are a lot of people who know how to do this stuff. But if you think about like, well, what are the classic papers in this area? Kind of fewer than you'd think. And I think there's a reason for that. That is not about like people not being good or not choosing the right problems. It's just that people don't have data. It is really, really hard to get data unless you're lucky enough to be housed at an institution that has already put all of its data online and made it available and made it frictionless for researchers to access data. So data is like the lifeblood of science. And there are examples of that from every part of science. The well-known ones in computer science are like, MNIST, the faces, like ImageNet, all these things, but it's every part of science. Like there was an early finance data set at University of Chicago that just gave birth to the field of quantitative finance. The Human Genome Project is basically a data play, et cetera, et cetera, et cetera. And they're not just any data sets. They're data that are actually accessible. So it's no good to have a data set and have it be the property of a large tech company. It has to actually be accessible to people who have the capacity to work with it. And the second criterion, and this comes from David Donahoe, who's a statistician at Stanford, who's worked a lot on these common task frameworks, as they're called, in a lot of different fields, is that they need to be optimized for collaboration and even competition. So a lot of the DARPA challenges and then ImageNet and all these other things, there was a task that people could put their minds to and start working on and start collaborating on and start competing. And there was a leaderboard and all these things. And so why don't these exist in health? Well, because health systems lock them away and don't let anyone outside of the health system touch them. And in some cases, they don't let people inside of the health system touch them either. And the people who control access to those data sets have very little private incentive to share. In fact, they have every incentive not to share, whether that's for risk avoidance, because if there's any kind of problem with the data, who's going to get blamed? Well, the person who opened up access to it. And because people have put a lot of resources into creating data sets and they want to write papers on those data sets, they don't want to just let random people from the internet write papers on the data that they've spent a long time collecting. So it's a classic public goods problem where there's this thing that would provide huge value to society, but that the individual decision makers that are controlling access to this thing are not letting it move forward because of incentive problems. And so health systems are the big part of the problem. Tech companies can buy access to these data, but they're buying access to the data to monopolize it, not to open it up to other people. And that's on the supply side. On the demand side, I don't think it's a controversial statement to say that health systems are not going to compete with Google or Apple for talent. They're just never going to win that competition. And the tech companies, even though they do occasionally produce good work, they basically just want to get hospitals on their cloud. And, producing nice things for hospitals to use is really an afterthought if you just look at the business model and the staffing at these companies. So unless you're in that lucky internal demand group, you get access that is super inefficient in the sense that there are huge frictions in getting access to the data that take years and years to manage. Like PhD students at Berkeley come to me and they're like, oh, I'm very good at machine vision stuff. I'd love to do health. And I'm like, great, we're going to add you on to the data use agreement. And then, in a year after that gets approved by the health system we work with, then we'll modify the IRB. And then we'll do, and by that time, they're already working at Facebook and it's too late. And so that process is both inefficient and also deeply unfair because, I'm super lucky that I was inside of health systems for a while and I know a lot of people and, it's just, why do I get to touch the data and a bunch of other people who are a lot smarter than I am and much more capable don't? It's just unfair. Okay, so a couple of years ago, my co-author Sendil Molnathan and I co-founded a nonprofit called Nightingale, which is a computing platform that starts by working with health systems to identify interesting data problems that they want to solve. So things where machine learning could add value, and then channeling a bunch of philanthropic funding from Eric Schmidt's foundation, which was our anchor funder, but since then the Moore Foundation, Ken Griffin, a bunch of other kind of tech forward donors who look at medicine and they're like, what the hell? Why is this so backwards compared to all of these other industries that I know? So we use that money to build up interesting data sets inside of the health systems that take aim at interesting and unsolved medical problems like pain. So we're building an X-ray data set of knee X-rays linked to a lot of patient outcomes related to arthritis as one of our data sets that's coming online over the next couple of years, I hope. And then we take that data out of the health system after de-identifying it, and we put it on our cloud platform where any of you can access these data for free. And so the data sets have three qualities. So first, they're large. They're kind of at least 5,000 images, at least 20% positive. So it has to be kind of something that you could credibly do ML on. And we focus on imaging. So all these data sets are anchored on a medical image. So a waveform, an X-ray, a biopsy image, for a few reasons. One is that there's a ton of really rich signal that I think humans are not fully exploiting in these images. So when I look at an electrocardiogram, I'm just like an ER doc, so I probably look for 5 things. A cardiologist is much smarter, they look at 50 things. But that's not all the signal there is in an electrocardiogram. So there's a lot of signal that machines could find that we can't. And the other nice thing about images is that even though there are some variations across sites and machines that are well known, compared to electronic health record data, they are super standardized across time and place as a signal. And the last important quality of these data sets is that they are labeled with patient outcomes. cardiovascular outcomes, cancer outcomes, musculoskeletal outcomes, not just what a human said about those images. And so hopefully the last example convinced you of the importance of that point. So if you go on to nightingalescience.org today, you'll find 5 data sets, ECG waveforms, biopsy slides, chest x-rays, and you can also enter our first data challenge. So this is a Kaggle style challenge that starts with biopsy images and asks people to predict cancer outcomes. We're offering $20,000 in cash prizes and free compute for the next few months. And so given the way the leaderboard looks now, I'm pretty sure that a bunch of you could make some money doing this. So I would encourage you to go look at the leaderboard and see if you can do better. It's an interesting challenge because these biopsy images are huge and very rich, and they're only weakly labeled. Each biopsy image only has the label of like, is this metastatic or not? And that's the whole rich image. So there's some interesting technical problems to solve that I'd say have not yet been solved. Okay, so let me close with lessons by going back to the lessons for algorithmic bias, which is don't take the score at face value. So when an algorithm is predicting healthcare costs, or when doctors are predicting arthritis from an image, don't assume that what the algorithm or the score is doing is the right thing for it to be doing, because it's often not, and that's often where the problems come from. Think super carefully about what the label should be, and remember that bias that comes from choosing the wrong label, it is racial bias, but it also hurts everyone because it distorts the algorithm away from the thing that the algorithm should be doing to optimize health in a population. And finally, strong argument, at least to me, to measure algorithmic bias in units of harm rather than in units of, is there a race correction? Is it population representative, et cetera? So let me end there, and very happy to spend the last few minutes on conversation. Thank you.
Amazing.
Michael. Oh, sorry.
Sorry, go for it if you want to moderate.
Oh, no, you should do it, Courtney. Sorry, please.
Okay, no, okay, we'll have Michael go first. He's right there too.
Well, thank you so much for a great talk. It's very interesting. I just had one question, sort of, you were touching on, you need to be predicting the right label. And I found this discussion about the competing causes of a disparity very interesting, but it seems like for some of these things, the right label is something that you couldn't even observe. It's, who would benefit most from knee replacement. Whereas if the disparity is due to, like a difference in medication prescription, then you don't want to offer more knee replacements necessarily. Perhaps you want to offer more medication. Is there a sort of a general way to approach this challenge?
Yeah, I think that's answering that question is what makes this work really hard. And it's why those of you who want to do this work will be in business for a long time. So there's one important technical point, which is that the way these things are often framed is estimating heterogeneous treatment effects. So, like who is going to benefit from high-risk care management? Estimating heterogeneous treatment effects is really hard. And so what a lot of these algorithms/scores do is substitute a simpler problem, which is to assume that the heterogeneous treatment effects follow from either the burden of chronic conditions in the first case, or from the, how much of a problem is in your knee versus outside of your knee in the second case. So I think that substitution is one of the things that makes it hard, because you're trying to make an educated guess about treatment heterogeneity as encoded in some proxy variable. And I think that's a hard problem. It's also a very rich problem, because I think, as we've seen over the past few years, it's really hard to estimate heterogeneous treatment effects purely from data. And I think that guiding that kind of work with a hypothesis is really, really useful. We have a paper, I'll post a link in the chat if I can multitask, on testing for heart attack, where we essentially predict who's going to have a positive test and then use a natural experiment of people getting tested more or less to show that that proxy identifies people who die less when they're tested more. So anyway, I think that's a really, really interesting problem. Now, I think that, choosing the right proxy, which is, I think, the other part of your question, is very, very hard, and it's very domain knowledge intensive. And so I think that that's where I don't think there's a formula for it. And I think it's very, very difficult, because you need to understand what is the treatment, what's the decision that's being made. And then you need to make some guesses as to like, what are the proxies that are going to track with that. And it's just difficult. And I haven't found a way to scale it up. Everything we've done has been really, really detailed work on a case-by-case basis, depending on the individual algorithm. A lot of that work is described in that algorithmic bias playbook.
Great, thank you. All right, Bettina.
Yes, hi. Thank you so much for your talk. My question is kind of related to Michael's question. Of course, you emphasize the importance of domain expertise in developing these non-biased algorithms, as was demonstrated in the osteoarthritis. I am wondering what other ways we can involve or engage the stakeholders, the clinicians, patients in improving algorithms, and to what extent do you think we should engage them, especially in deciding the label for the proxy?
Yeah, I think what's difficult is that I think all of you in this room, virtual room, are technical people who have made huge investments in learning about health. And I think that you can't just choose a randomly drawn physician and expect them to be helpful in this enterprise, because physicians also need to make a huge investment in understanding data and like how data works and statistics. And sadly, that is not something that our medical education system is preparing us to do. I think I knew less about statistics after medical school than I did before medical school. And so I think that that said, there are a bunch of really, really talented physician scientists in this area. And I think there are more and more, no thanks to our medical education system, but just because those people are getting a great education as undergraduates or in industry or in other jobs before they go into medicine, and they're carrying that over with them. So I think that you need to pick your physician partner super carefully as someone who is, bilingual in this way. And then those people I think are super, super valuable. And I'm, in both my research work and then in some of the applied work I'm doing, I've found that those people are tremendously valuable for solving these problems. And so I think chosen carefully, it's a great idea.
Excellent question. Thank you. All right, Dr. Bakken.
Thanks for the great talk. One of the roles I play is I'm an editor-in-chief of a journal, the Journal of the American Medical Informatics Association. I just wanted to hear your thoughts about how can journals and journal editors move forward on this topic. It's something I think about all the time. Every time we publish a paper on predictive modeling. Do we need better guidelines? What are your thoughts? How can we make sure that what gets out there is equitable?
Thanks so much for asking. I'd love to maybe think more about it with you. I think off the cuff, I think there are a couple of things that I would suggest. One is just, and I know that Jamia has been kind of moving in this direction, but just data sharing, I think, is really, really important. I think that being able to build a repository of data as we go in an ethical and secure way is super, super valuable. And I think journals have a really important role to play in basically enforcing that norm. I think on the bias front in particular, I think it would probably be useful to have some guidelines for what is bias, how do we define it, what are the different elements that we consider to be, demonstrative of bias. And I think that there are surely some guidelines that could be written. But I think that, even in a general purpose article that's not about bias, I often find it really hard to figure out what is the label that algorithms are actually predicting. Like it's often buried very deep in the article. It's very hard to figure out. And so I think having guidelines on, what is the label? What is that label trying to approximate? And enforcing that kind of thing could be super valuable. And in some of the editorial work that I'm starting to do, that's a really important priority.